So before we go on to what do we do after CDK4/6, which is a really, really interesting question, let me ask Heather. So Heather, do you think there's any reason to use fulvestrant upfront with a CDK4/6 inhibitor, or no particular advantage over an aromatase inhibitor with CDK4/6?
Well, I think it depends on the specific scenario, and as we just touched on the prior exposure to aromatase inhibitor, the duration of the exposure to the prior aromatase inhibitor. So I think it really is dependent on their specific history. I think tangential to, not to answer that question, but I think one of the interesting things that actually came out of the Paloma data was the time to chemotherapy. And the fact, because there was this sort of discussion in the background about whether CDK inhibition exposure was actually creating a more aggressive kind of phenotype of disease. And that really was concerning to a lot of us. And it was really influencing our decision about applying CDK inhibitors to the first line versus waiting until a later date, especially in the absence of any clear survival benefit with all the preceding reports. So that was very reassuring to me, that the time to chemotherapy was the same, indicating that there wasn't this biologic change, at least for the population overall.
That's a very good point.
Yeah. But now with the MONALEESA-3 data, we have FDA approval for one of the CDK4/6 inhibitors with fulvestrant. In the first line setting. Probably biologically, you could use any of them, but from an FDA approval standpoint, we have ribociclib and fulvestrant. So like you said, it just depends on what the previous exposure was and
the duration of exposure.
Yeah, duration of exposure.
Is driving your ESR1, your likelihood of an ESR1 mutation.
And the menopausal status as well, because we have data, of course, in combination with tamoxifen.
Right.
Yeah,
so,
but we can't use it. We can't,
that was ribociclib, that was
Not with ribo, yeah.
Yes. But it is good to know. It is good to know that if you think that you'd rather have fulvestrant, now at least we have that option, first line for patients. Any times that you would choose abemaciclib first line, with MONALEESA-3, that's with fulvestrant, the ribociclib is a differentiator there, if you will. It also has the premenopausal FDA approval. So that's the first line, MONALEESA-7, ribociclib, letrozole with an LHRH agonist. Second line, we have data in the premenopausals with both palbociclib and abemaciclib. So second line, so we have premenopausal data with all three agents, but in terms of FDA approval, we have the first line with the ribociclib. But in terms of our three choices up front, is there any time people prefer one over another? Any subsets of patients, let's say? Anybody?
It's tough. I think the biggest thing for me would be the risk of neutropenia. I think if someone comes in who's really been beat up from her adjuvant chemo, maybe has had adjuvant chemo before we've used hormones or whatever, maybe that's someone I would consider that, because there's clearly less neutropenia with abema.
With abema, less, yeah. So if
but you look at the curves, they're all superimposable.
Right, and the hazard
And the
ratios
hazard
are
rate-
just...
The hazard ratios are the same. It's going to be hard to, you're really making a decision based on side effects, right? More than anything.
I have to
And
say,
monitoring.
Yeah, I have to say I've been using abemaciclib mostly as monotherapy in the chemo-refractory populations, particularly when there's a history of brain metastasis because of this potential penetration, CNS penetration. So that's been my primary application is monotherapy.
I think the problem is that, not the problem, but we were all very used to using palbociclib now. So, that's one of the issues. I think if I had a premenopausal patient just following the data, I might consider ribo in that patient because it really seems very similar side effect-wise to palbociclib, I think.
This is interesting. I guess the question is, we don't know. Because the other two agents have not been looked at in precisely the same way as the New England Journal of Medicine paper that carved off that 20% that were primary refractory, where there wasn't a benefit from palbociclib. So the question is, but we don't know the answer, is whether ribociclib or abemaciclib would be different. I heard with interest here from MD Anderson in a poster discussion, I heard with interest preclinical work differentiating abemaciclib, saying that it inhibited, across a bunch of whole cell lines, it inhibited not only CDK4/6, but also CDK1 and 2. And so that's the cyclin E, but also not only shut down cells in G1, but also G2. So some differentiating characteristics, And so I tend to utilize it in those patients where I think the degree of endocrine therapy resistance is going to be higher. You know, and that I'm worried that I really am in an endocrine therapy resistant, kind of like where I used to use chemotherapy, because I'm using much
could rely on
So
it
it's
as
interesting,
a
they have some
monotherapy.
data, I think it's
Yeah.
with Ribo, there is some data, translational data from Ribo that if you have cyclin E overexpression, you don't respond as well.
That's right. No, that's with palbociclib.
That's with Palbo, it's with one of them, I just didn't know which one it was.
Yeah.
And I think also there is some preclinical data saying that Abema's the only one that really causes a lot of apoptosis. The other two do not as much. So, I mean, I think when you look at, you know, some of the discussion is this response rate higher with abemaciclib, but actually if you look across the trials, look at the patient population, it's very similar. So I
Yeah,
just
no,
don't think
it's
you can
level
make that
one
case.
evidence, level one
Even though they
evidence
have
is-
all this great
Yeah.
preclinical data,
Yeah, no.
clinically, we just haven't seen any difference,
Right.
that's the issue.
No, if we're taking our boards, we check all, you know, they're all the same, basically, of course, you know, of course. But there are some interesting questions arising.